Hey there everyone, Henry here. So today we're going to go over the top 5 sonographic signs in gynecology. The objectives of this lecture is going to be anatomy and technique. So we're going to go over pretty much basic anatomy. We're going to go over those signs and their interpretations with case review. And then at the end, we're going to have a bonus round of perhaps new signs that we can add to the list of signs we already have in gynecology. So first of all, why signs? In medicine and radiology, we use mnemonics all the time to remember a vast amount of data. So signs in radiology facilitate learning. They're going to improve recall, which is very important. We're remembering a lot of data, a lot of different anatomical and pathological things, and we need to be able to quantify those things in our brain and put them in little folders. It enhances patient care. The fact that we know diagnoses and anatomical variations is only going to help them arrive at their diagnosis and then further treatment. It increases efficiency. Categorizing things allows us to put things in their proper places. It standardizes information, and lastly, it makes learning fun. All right, so the anatomy that's going to be important for us in the pelvis, at least gynecologically speaking, is going to be the uterus, the endometrium, bilateral ovaries and adnexa, and any potential spaces around the ovary, around the uterus, and around the ligaments. So this is just a sagittal view of the uterus, using the bladder as a window. So here you got your uterus and sagittal. You got your vagina, cervix, fundus, body of the uterus. Here you got the endometrium. If you were to measure this endometrium, you'd probably measure from here to about here. If you're getting a transvaginal image, you'd have a much higher resolution for proper measurement. Tiny bit of physiological free fluid here and here, which we see all the time. No big deal. Typically, when we're going to use pelvic ultrasound, we're going to be using a transabdominal approach or a transvaginal. Transabdominal is right here. Transvaginal does have the fact that you're closer to the uterus. You can use a high megahertz transducer, an endocavity transducer up to 10 megahertz, even 12 megahertz, and you can get very, very, very detailed views of the uterus and ovaries. So this is a preferred method, but the transabdominal method is very good, especially in the pediatric population. There is also a translabial approach where you can use to see the vaginal canal and maybe the cervix. A transperineal approach as well, but those are less common and used for certain things. Maybe if you had like a Gartner's duct cyst or something that you wanted maybe a higher resolution view of this area here. You know, I've done it also for imperforate anus, things like that. If we're going to be doing transabdominal ultrasound, which most of the images I'm going to be sharing are transabdominal, as I am a pediatric sonographer, the bladder needs to be full. Now here you have one case where they come to you, bladder's not full. Now here you got the bladder is kind of full. And honestly, if you were to come here, so here you're in the lower abdominal wall. If you're in the lower abdominal wall and you slide all the way down to the symphysis pubis, so you'd be going this way, all the way down to the symphysis pubis and angle up, you're going to be approaching the uterus from around here, and then the sector will be around here. So you get a clear view of the uterus and the ovaries. But in this method, you know, you have to use more pressure. It's more uncomfortable for the patient. It's better to just have them fill their bladder more. Obviously, sometimes you know, if they have something that's serious that needs surgical attention, you might not have the luxury of waiting a very long time. So that's perfect. But here you can see the bladder is completely full. The bladder is passing the fundus of the uterus. And with sweeps from side to side, you'll be able to see all the anatomy very clearly without having to put too much pressure. All right, so what do we have here? Here it almost looks, you know, to the untrained eye, where you have a full bladder, maybe a bladder with a diverticulum, and then the uterus, trace-free fluid here. And you think, oh, this patient's ready to scan. Actually, this is the bladder here. It's empty, and this is an ovarian cyst that's in front of the uterus, acting as that sonic window that the bladder usually acts as. I call this the ovarian cyst assist. All right, so the spaces. You know, all around the uterus and the lower abdomen, you're going to have peritoneal and retroperitoneal potential spaces where fluid can accumulate, whether it be just ascites fluid or blood. So here you have the... so most commonly, you're going to see fluid in the rectal uterine space, or the pouch of Douglas. That's the most common space, which would be around here. See here, you have a completely empty bladder, but with the linear probe, you can see the entire uterus. So here you can see the uterus is all the way tilted forward. Now, when you fill the bladder, that uterus is going to move backwards and it's going to look more like this. So here you can see the potential spaces. Pouch of Douglas would be around here. The vesicouterine space would be around here, which is this. And in patients with, cardiac disease, kidney disease, liver disease, if they accumulate a lot of ascites, you'll see pretty much fluid all around the uterus. And we'll be going over that later, as one of the signs does pertain to that. Here you can see the vaginal canal, and right behind it you can see the rectum. So this rectum is pretty empty, maybe a little bit of air there. So you can see pretty much everything, even though the bladder is not full. This is not always the case. If there's a lot of bowel around the uterus with feces and gas, you are not going to see pretty much anything. All right, so here you got the rectal uterine space, or the pouch of Douglas. This is pretty typical in ovulating women, especially around the peri-ovulatory phase. If they ovulate, if the ovary releases the egg, that mature follicle will rupture and that fluid will kind of leak into this space. So this is a normal amount of fluid, nothing to really, cause any alarm. We see it very frequently. Sometimes it's a little less. When it's more, you'll see it in both adnexa, you'll see it in the fundus of the uterus, around this space right here. All right, so this is that other case, another large cyst, ovarian cyst to cyst. Maybe we should make that a sign as well in the bonus round. The ovarian cyst to cyst sign, that's too many words. All right, so you got a bladder that's not very full. Here's your vaginal canal, here's your uterus, fundus, and this large cyst that ruptured during scanning. Unfortunately, I couldn't get the clip of the cyst rupturing or becoming smaller. I even asked the patient as I was scanning them if they felt anything. They said no. So this person pretty much had their ovarian cyst rupture in real time. They felt no pain, but then you can see the fluid from that cyst start to accumulate in these potential pelvic spaces. All right, and then this is a case where you have blood. This was an ovarian hemorrhagic cyst that ruptured, and in fact, there was a lot of blood. Here you see a lot of blood in the cul-de-sac by the fundus of the uterus. There was blood in Morrison's pouch in the right upper quadrant, in the left upper quadrant. Pretty much all quadrants had fluid. Some of it was kind of anechoic with some echoes, which is, representing more fresher blood. And then some of it in these deeper spaces was more echogenic, representing clotted blood. All right, so now on to the ovaries. All right, so now on to the ovaries. The ovaries are paired organs on either side of the uterus. Now, they're being anchored by the ovarian ligaments and all the other, structures. They're very mobile. They're not going to be very fixed, like let's say a kidney or a gallbladder. So you can have, there's a lot of variation. So they play a role in estrogen and progesterone releasing in women. They also play a role in menopause. After menopause, they do atrophy and become very small and release less of these hormones. And the normal size is around 2 to 3 centimeters in length, sometimes 4. And the typical volume is around 6 to 7 milliliters. That also has variance with age, where they are in their cycle, whether there's a dominant follicle or a corpus luteum, etc. So here's the ovaries with a curved probe, sagittal and transverse. Here's the same ovary with a linear probe, slightly higher resolution, sagittal and transverse. And then one with a transvaginal probe, which is the best view you can get of the ovaries in regards to resolution. You can see all the tiny little immature follicles. Obviously, this is the best view you can get of the ovaries, but these are very, very valid as well. All right, so on to the ultrasound signs. We're going to be going over 5 signs. Ring of Fire, which is a famous one everyone knows about. You got the TIE Fighter sign, Whirlpool sign, the Cogwheel sign, and tip of the iceberg sign. And then at the end, we'll go over a bonus round with other variations and potential signs in the maybe that we can add in the future or just for fun. So the Ring of Fire is a hyperemia, circumferential peripheral flow on color and power Doppler due to low resistance blood flow. So there's a lot of blood going to the structure. The structure is circular and there's a ring of vascularity to it, which is going to have color, and power Doppler flow in all parts of the cardiac cycle. It's going to be increased flow. It's going to be very obvious flow. Now, it is extremely, extremely common in corpus luteum cysts. It can also be seen in ectopic. That's why most people, when they see the ring of fire, their first go-to is ectopic. But obviously, there's a lot of other things to consider, like whether they're even pregnant. And another thing to consider, if you see an intra-ovarian ring of fire, the possibility of it being an ovarian ectopic pregnancy is pretty small, because ovarian ectopic pregnancies account for 3.2% of all ectopic pregnancies. So it's not, the chance is not zero, but there's many, many things you need to consider before that. Like, do they have a positive beta HCG? You know, are they pregnant? And it can be seen in other anatomical structures that are circular or cylindrical, or have inflammatory processes in the organ that are circular. So here you have a corpus luteum cyst, or a hemorrhagic corpus luteum cyst in a female in her periovulatory phase. You can see the ring of fire with power Doppler and color flow Doppler. And you can see the spectral Doppler is showing a low resistance waveform, which is typical of ovarian tissue that's ovulating as well. And here we have a clear view of that ring of fire, but with an actual ectopic pregnancy. So here we have an appendix. It was a very large appendix. It was over a centimeter, but this can be seen in the adnexa. And you think, oh, what is this? Is this an ectopic pregnancy? No, it was just an appendicitis with that ring of fire type of flow. And here's another adnexal lesion. Here you can see the ovary with some flow, and then this circular structure next to it with free fluid. It's a very complex structure. You can tell it's not in the ovary, so this is kind of concerning for an ectopic pregnancy, but the beta HCG was negative. So this turned out to be a tubo-ovarian abscess. So remember, not all ring of fires mean ectopic pregnancy. All right, let's go on to the TIE fighter sign. So the TIE fighter sign is a fun one because it's associated with Star Wars, and Star Wars has a very large fan base. Given that fact, a lot of people know what a TIE fighter is, so it allows you to remember or recall this sign with the certain pathology. So the appearance of the TIE fighter is the appearance of the uterus and ovarian ligaments in the presence of a large amount of intraperitoneal fluid, so ascites, or any type of fluid, honestly. It is, like other signs, uses a mnemonic for training. Here I wrote the anterior portion can be ascites or the bladder, but not really. It usually should be ascites and ascites, both anterior and posterior to the bladder. And with the, I'll show you now. The posterior portion is free fluid in the pouch of Douglas. So here we have a uterus with the ovarian ligaments, and a large amount of free fluid here, and a large amount of free fluid in the posterior part. So that's why they call it TIE fighter, because it resembles the TIE fighter from the Star Wars movie. Now, this is just a sign that can help for people that are training. You obviously don't need this sign to know that this is a large amount of intra-abdominal fluid. But as we like to make learning fun and recall better, this is a good sign. Now here is a very small uterus in a very young pediatric patient, and here you have the uterus, some free fluid in the cul-de-sac. This is bowel, and then here, this kind of looks like the TIE fighter sign as well, but for somebody who's untrained, they might see that and think, oh, TIE fighter sign, large amount of fluid, but this is actually the bladder. So I don't really think anybody's going to be mistaking this, but this is just to show you how these things can mimic other things. So a pseudo TIE fighter sign. So it's good to know the pitfalls with these signs as well. All right, now we go on to the cogwheel sign. So the cogwheel sign is a sign that's related to hydrosalpinx. So here you can see the ultrasound image with these little projections here, like that, and it resembles a cogwheel. So it represents a fallopian tube that is fluid-filled with thickened folds along the periphery, producing the cogs. So this is a patient. Here you have the bladder. This is the uterus, and this is the cystic structure in the right adnexa with the cogwheel sign, and this was a case of hydrosalpinx. Here in this clip, you can see the uterus, and here, those are the little cogs, and this is a hydrosalpinx. Okay, with the linear probe, here you have the bladder, the uterus, and then this tubular structure here, which is definitely the hydrosalpinx. Now, do we need the cogwheel sign to diagnose or identify hydrosalpinx? Absolutely not. You have this tubular serpiginous structure in the adnexa. Apart from it being maybe a para-ovarian cyst or a fallopian tube cyst, the most likely diagnosis is a hydrosalpinx. Now, there's echogenic debris within this, and you could say perhaps, and there's maybe elevated white blood cells or inflammatory markers or signs of infection, pyosalpinx, or if there was blood, hematosalpinx. But for all intents and purposes, this is the hydrosalpinx with the cogwheel sign. So you'll have to get that fallopian tube in a transverse view to get that cogwheel sign. All right, so now Whirlpool sign. Now, the Whirlpool sign can be seen in many places, but it usually results in a volvulus of a twisting vascular structure. So you'll have a structure that has a vascular pedicle, much like the ovary or a testicle for that matter, and that twists along the pedicle, and that creates a volvulus. And it can be seen anywhere where any structure or any organ that can revolve around a pedicle. Usually is a surgical emergency, because that twisting is going to lead to lack of blood flow, eventually ischemia, and then eventually necrosis or death of that tissue. So here's a patient we had a very large cyst. Here you can see the bladder, the uterus, the cyst, and this is the laparoscopic view of that, and you can see this is a torsion right here. So if you're able to see that and image it with color Doppler as well, you will see the volvulus. You're going to have, usually in the structure that's twisted or torsed, you're going to have absent or decreased blood flow. Decreased blood flow because, remember this, the ovary has dual arterial blood supply. So you can have an ovarian torsion and still have some blood flow, depending on the acuity of the torsion and the fact that the ovary has a dual blood supply. So the twisted vascular pedicle is what gives you the Whirlpool sign. In the ovary, you can see a string of pearl sign, which is another sign that I didn't add, but that's peripherally displaced follicles due to the fact that the ovary is now getting edematous from the lack of venous outflow. It's getting edematous. So early on in the torsion, you'll have lack of venous outflow, but you still might have some arterial inflow, high resistance arterial inflow, until that goes on for enough time and the edema gets so bad that blocks the arterial inflow as well. And then, you start to get into the territory of ischemia and then necrosis. You might have free fluid around these structures, and you might have displacement of the uterus. Depending on how severe the torsion is, it might twist, and pull the uterus towards it. All right, so with ovarian Doppler, prepubertal, you're going to have low diastolic flow. It's going to be much like young patients or pediatric patients, very young patients for testicular ultrasound. They're going to have very little blood flow, and the blood flow they're going to have is not going to be very high resistance because their gonads are not really that active yet. Once you get to the post-pubertal phase, and depending on what phase you are in your menstrual cycle, you're going to have different types of flow. So in the follicular phase, the early days of the cycle, you're going to have low or absent diastolic flow. There's usually some diastolic flow. In the follicular or luteal phase, which is very active, you're going to have increased diastolic flow. And then later on after that, you're going to have slightly decreasing diastolic flow. And in 90% of the adolescents, you should detect some flow in the ovaries. You might have to work around with the scale by decreasing the scale all as much as you can before you introduce artifacts, and then obviously also working with the gain. All right, and arterial flow can be detected with a torsion of the ovary, again due to the dual ovarian blood supply. So finding a volvulus in a torsion is not always A, possible, or B, necessary. If you have two ovaries and one looks normal, the other one's much large, over 3 to 4 times the size, and echogenic. That's another thing I failed to mention. Ovarian torsion is also going to show increased echogenicity in the more acute phases of ovarian torsion of the ovarian stroma. Here you can see the peripherally displaced follicles, so the string of pearls. Here, not really, you just see like one pearl, but you see the echogenic, slightly heterogeneous echotexture of the ovarian stroma. And later on, as much like testicular torsion, as this sets into a further ischemia and necrosis, the ovary is going to be much more hypoechoic. So these are 3 cases of ovarian torsion, 2 in the earlier phases with echogenic heterogeneous ovarian stroma, 1 ovary much larger than the other, and lack of blood flow, obviously, and then the peripherally displaced follicles. But here we have a transvaginal view of some free fluid. That first part was the ovary, and you can see the twisting right there of the adnexa. Now, unfortunately, this clip does not have a color Doppler, but if you did put color Doppler on there, you would have a lot of, you would have the volvulus, or the whirlpool sign. All right, so that was a case of ovarian torsion with volvulus. Now, volvulus, like I said, can be seen in many, many other organs. This is a case of midgut volvulus. Still follows that same pattern of the twirling vessels. It almost looks like a hurricane on the Doppler maps in the Weather Channel. So again, these are surgical emergencies because that can lead to ischemia and necrosis of that tissue that's being deprived of the oxygen or of the arterial blood flow. Here's another example of midgut volvulus. You can see the superior mesenteric artery here in the middle, and then the superior mesenteric vein and mesenteric vessels going around the volvulus. So again, yeah, the whirlpool sign is a very important sign to know about in ultrasound and in radiology. Here we have another whirlpool of the testicle. So here you got that same whirlpool sign. So that's that twirling of the spermatic cord, which is going to lead to ischemia of the testicle. So even though there was torsion, you can see there was some flow in the testicle. So that's very important, because had we just imaged the testicle and Dopplered the testicle and showed color flow and pulse wave Doppler, we would have missed this spermatic cord torsion. So this was a testicular torsion. All right, so next is the tip of the iceberg sign. This is one of many variations of dermoids or teratomas of the ovary. Could be seen in 10 to 20% of dermoid cases, especially when they're over 5 centimeters inside. It's not very specific. It can be it can be confused for other things as well. And the tip of the iceberg sign is usually have a hypoechoic center and a hyperechoic periphery. So you have pretty much a very echogenic edge with shadowing causing hypoechoic center. So here we have an adnexal lesion, and you have that tip of the iceberg sign where we have the echogenic part right here, and then the shadowing. Now, anytime you see something like that in the adnexa, you got to make sure it's not something that's not a dermoid. It's not bowel. We've actually had cases that have been misdiagnosed as dermoids because you see something like this. You have this echogenic structure that's causing that shadow kind of tip of the iceberg sign, some free fluid, and it's concerning for dermoid. So one thing you got to do is make sure you find the ovary on that side. So here's the uterus. We're in transverse, and this is the right, this is the left. So if you see the ovary, this is not the ovary, this is bowel. But if you see the ovary right here, perfectly intact, and then you see this, you know it's not an ovarian dermoid. You can tell that this is bowel. If you use a higher resolution image, you maybe see the gut signature of the bowel. You can also wait, scan them a little later, see if this is gone, because as you're scanning, this might not be actually peristalsing. So it can be very confusing. So just be aware of that. All right, so on to the bonus round. Now we're just going to go over a couple things that are just... So on to the bonus round. Now we're just going to go over some things that I like, maybe suggest a new sign for these structures. All right, so now on to the bonus round. Now these are things that are signs that are known, and I just want to talk about them because the title was 5 gynecologic signs, or maybe new signs, new proposed signs from things I've seen. So let's go right into it. The first one is going to be the light bulb sign. Now, this first sign that I'm going to be talking about has to do with Mullerian anomalies. Now, we're very aware of all the different types of Mullerian anomalies that there are, like didelphys, bicornuate, unicornuate, all that stuff. So the one I'm going to be talking about is cervical agenesis. And then at the end, we're also going to talk about didelphys or bicornuate uterus. So here, the light bulb sign, which I guess a second runner-up would be the map pin sign, but that just doesn't really roll off the tongue, but similar to either or, light bulb or map pin. So here you have the uterus with a linear probe, and this is with a curved probe, full bladder. So here you see the fundus of the uterus, and no matter where you went, the lower segment of this uterus was either appeared hypoplastic or not there. And here you got the vagina. And then here we have the MRI. And you can see this is all there is of the uterus. So there is no lower uterine segment. There's no cervix. So this was a cervix agenesis, which my ultrasound, I said it was either going to be cervix agenesis or cervix hypoplasia, but that's why they do the MRI, because it's much, you get much better detail. And it was a cervix agenesis. So it kind of looks like a light bulb, if you squint a little bit and use your imagination. But here's another case where, this looks like a light bulb. If you ask me. So I propose that cervix agenesis should be called the light bulb sign or the map pin sign. But I like map pin because usually, which I forgot to mention, with cervix agenesis and postpubertal women, you're going to have hematometria as well. So you're going to have fluid inside the endometrial cavity, which represents blood. As you can see here as well. Here, here, here. And this one much more clear. So the map pin sign could kind of look like that as well. Maybe you guys could come up with a sign that's more fitting to this pathology. All right, this one is from Radiopedia, and it's called the Pokeball sign. So any fans of Pokemon know the Pokeball. I don't know anything about Pokemon. I know of it, but I've never really watched the show. But I know enough of it to recognize this as that Pokemon ball, right? So this is from Radiopedia, and this is a little illustration that my friend, the Radiologist page on Instagram, did. You should give him a follow. He posts a lot of good stuff, where he also, does illustrations over the structures for students to know what they are looking at. So supposedly it's supposed to be pure fat, some fluid, and a dirty fat ball, which that just sounds hilarious. Dirty fat ball. So the Pokemon ball sign or the Pokeball sign is a cool sign to learn. Now, there is no ultrasound counterpart for this sign, because if you scan a dermoid that looks like this, you're not really going to get the same appearance due to the different densities of the structures. But in ultrasound, there's a lot of dermoid signs. You can have one that has a lot of fat globules, which I'm going to go over. You can have extremely heterogeneous dermoids, and that's where this next sign is. Now, I know sonographically we can see these dermoids or teratomas with fluid and then separate fat globules, as here and also in this example, which is pretty impressive. Now, this could, I don't know if anybody's ever proposed this, but it looks like a bag of Orbeez. So maybe they can call that the bag of Orbeez sign. And then here, a very, 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 very classic, didophic uterus or bicornuate uterus. I don't know if anybody's proposed this, but it looks like bunny ears. Maybe they have, and I just, in my almost 20 years, have missed it. But, they can call this a bunny ear sign. And if they have already, then let me know in the comments. I'm pretty sure you guys know. But I like that. That definitely does look like bunny ears. Now, that doesn't really tell you give you much information on whether it's, a complete didelphic uterus versus, a bicornuate uterus. But still, for people who are learning, that could be something of a mnemonic that they can use. Okay, this concludes the lecture. Hope you guys found this useful and learned a couple things. Thank you. Bye.